Well, hello everyone. This is Professor White, and today we're going to be talking about coagulation modifier drugs. So drugs that somehow impact the coagulation system in our bodies. First things first, let's get a couple of definitions out of the way. The first one is hemostasis. So hemostasis is basically stopping the bleeding process in the body. So when our bodies are clotting, that is called coagulation. In our bodies, we're trying to maintain a balance between clot formation and clot degradation. So there are things in our body which cause clots to form, and also other things in our body like protein C, which causes the breakdown of clots as well. So when we talk about blood clots, the actual term is called thrombus. All right, you can see I have a little picture here of a vessel that has a little tear in it, and you see lots of thrombocytes or platelets plugging in there. And in there would also be fibrin and some other clotting factors. A thrombus becomes an embolus when it moves, so once it gets on the move. So blood clots can travel throughout the body, and where they end up is basically what we would call them. So most emboli do start in the deep vascular system of the lower extremities, so DVT. That happens in the vein of a leg. And then as the body pumps them up and out, then if they go into the heart, it's called a myocardial infarction, which again, embolisms don't have to come from leg clots. In fact, our cardiac, I think, is generally coming from ruptured atherosclerotic plaques that become embolic. But pulmonary emboli do tend to come from the lower extremities from DVT. Now, strokes, on the other hand, one of the main causes of strokes in our patients that are embolic events is going to be atrial fibrillation. And, of course, the potential for ruptured plaques as well. When we speak about hemostasis in the human body, we're actually talking about the coagulation cascade. So basically, it's one event that leads to another event. So it's kind of like a domino reaction. If you were to set up a domino course and knock one down, and that knocked the other one, which knocked the other one, which at the end of it drops the marble into the pail, or in our case, results in the clot being formed. So we do have the intrinsic and extrinsic pathways. So let's take a look at that. All right, so intrinsic and extrinsic pathway basically just depends on whether we're having an internal sort of vessel ripping, sort of an internal bleed, versus external, where the tissue has been injured externally. So you can see that the intrinsic pathway starts with factor 12 to 11, down to 9 and 8, and you have the extrinsic pathway starting with factor 3 to factor 7, but where they both come together, that common pathway is factor 10. And once we start working on that common pathway, eventually we end up with fibrinogen being turned to fibrin. Factor 13 gives us stable fibrin, wraps up the platelets in there, and we now have a stable clot. So this is the clotting cascade. All right, so the fibrinolytic system then is sort of the body's answer to the coagulation cascade. This initiates the breakdown of clots in our body, because if the clots were allowed to build up and never break down, well, we would just have clots all over our body. So again, we want a balance between clot formation and clot degradation. When we speak of the breaking down of a clot, the lysis of a thrombi, we call that fibrinolysis. So basically, the fibrin is lysed, and that breaks up the clot. As we go into the understanding of these medications and discussion on them, please realize that medications that affect the clotting cascade are some of the most dangerous drugs that we use, even though we toss them around like candy some days. They're very dangerous. We have drugs that can cause serious bleeding and have effects on the patient's well-being and morbidity and mortality as well. And again, a lot of different things affect how the drug will work in a patient, and the drug's pharmacokinetics and pharmacodynamics, and at the end of the day, how the patient fares. All right, so the class that we're going to start with are the anticoagulants. So anticoagulants are used to prevent clots when clot formation is likely. So when somebody's had a heart attack or unstable angina, people with atrial fibrillation, anybody who has a mechanical heart valve, and after major orthopedic surgery, so joint replacements, things of that nature. Anticoagulants prevent the formation of thrombi, but they do not dissolve or stabilize any existing clot, okay? So you have to understand that they won't do much for the clots that are already in play, but they will prevent the formation of other clots. And again, that's why we use these prophylactically. Patients in the hospital are often on heparin every 8 hours or Lovenox every 24 hours. This is to prevent venous thromboembolism, or DVTs. All right, so adverse effects of anticoagulants really are bleeding, and the higher the dose, the more likely the patient is to bleed. And the bleeding can happen widespread or can happen in a very localized area. So because of the risk of bleeding, you should always double check what's happening when you see orders for 2 anticoagulants at once. The only exception to that is something called bridge therapy, right? So bridge therapy is an overlap of therapy for patients who have been receiving heparin or low molecular weight heparin, so Lovenox, to be switched over to warfarin so that the patient always has protection against clotting, right? This is done on purpose because warfarin takes 3 to 5 days to actually become therapeutic, and the heparin is active as soon as it's given. The Lovenox is active as soon as it's given. So basically we would stop the bridge therapy or stop the subcutaneous heparin or low molecular weight heparin once the INR, which is the lab used to monitor warfarin, is above 2. All right, so heparin is one of the more common medications for anticoagulation. It is used both prophylactically, subcutaneously, and also used intravenously for therapeutic treatment of embolism and clotting. So it is porcine in nature, so perhaps you have patients who are against using pork products. This is considered a pork product. It is porcine. It is available in different concentrations, so please be very careful. This is a high alert medication. If we're just using heparin for DVT prophylaxis, we do not need to do the drug monitoring. However, when we are giving this medication intravenously, it is very important that we measure those indices which tell us that our bleeding times are within the specified parameters. So we may use the APTT or the anti-XA. So when we are giving these medications intravenously, the standard is to have those ordered every 6 hours. And you need to check their CBC daily because of the high risk for bleeding and also for a heparin-induced thrombocytopenia. So we're definitely paying attention to those platelets and hemoglobin, making sure our platelets don't fall and our hemoglobin doesn't fall. All right, so heparin works by inhibiting 2A and also XA. And when we have our unfractionated heparin, that's called heparin, and low molecular weight is called Lovenox. So the big difference between Lovenox and heparin is that Lovenox does not need to have lab monitoring with it. So we like it for that reason. But in our patients who have epidurals, that this medication must be stopped prior to removing any epidural catheter, or else the patient will have potential for epidural hematoma. All right, so there is a decreased risk of heparin-induced thrombocytopenia with enoxaparin or Lovenox, and so that is desirable. Giving heparin is a skill in itself, so It is generally given in the abdomen, in the subcutaneous regions of the abdomen, avoiding 2 inches around the umbilicus, any open wounds, scars, things like that. So anything that's going to inhibit the absorption of it. We never aspirate, we never massage the sites where we're giving heparin because it will cause massive bruising and hematoma. And in the case of IV dosing, that we may give it IV push to bolus dose them or by infusion. In that case, because of the route that we're giving it, we see the anticoagulant effects immediately. So that's why we give IV heparin to people who are having myocardial infarctions in the ER. So I gave you a little belly here where you can sort of look and where you might want to give your heparin and perhaps your Lovenox injections. Again, most common being on the abdomen, also in the thighs. For heparin, you want to select a 1/2 inch to 5/8 inch, 25 to 27 gauge needle. Make sure you use the appropriate technique. Remember to rotate sites with our injections. Enoxaparin will be our prototype for our low molecular weight heparin. Remember that these are contraindicated in patients with the indwelling epidural catheter. We wouldn't want to give it until at least 2 hours have passed since it's been removed. This really does act more specifically on XA rather than heparin, which had 2 different pathways. No labs need to be monitored. It's injectable. Patients can inject it even at home. It comes in pre-filled syringes. And a couple little things for our enoxaparin. That little bubble that's in there, if you've ever seen it, if not, you will. Don't expel that bubble. That bubble is to be the last thing injected. It's a gas that propels and locks the medication into subcutaneous tissue. And the other thing that I've always remembered is Lovenox means love handles, right? Because of the risk of hematoma formation, you want to kind of get over into that beefy subcutaneous area. All right, so let's look at heparin-induced thrombocytopenia. There's 2 different types. One of them is that the platelets are just kind of falling, and doctors can monitor that and continue to watch. As long as there's no other problems, they may continue the therapy. Type 2, though, is an actual allergy to heparin. So basically what happens is that the platelets actually fall, at least 50% from baseline. And understand what's happening when a patient has an allergy to heparin. It's actually inactivating the heparin, causing the patient to be in a more coagulable state and causes clots to form, which would account for the fall in the platelets. So your patient who's on heparin who develops a clot, we would want to consider this to be heparin-induced thrombocytopenia. And if that's the case, if a patient is experiencing HIT or HIT, as it's called, we want to go ahead and hit the stop button on heparin. And this means all heparin products, including molecular weight heparin, like Lovenox. They should not have that ever again. And if they still need anticoagulation, then we might want to place them on argatroban. Now, a cultural consideration is that many Native Americans do have the propensity to develop heparin-induced thrombocytopenia. So it's common that you'll see your Native American patients be placed directly on argatroban if available, or if they've ever had a history of HIT. Again, it's more likely in them. In the event of heparin toxicity, whether it be from an overdose or the patient having quite the interesting reaction to heparin, and the patient may develop bleeding. So signs of bleeding are listed for you. So they may have blood in their urine or hematuria, melena, which is blood in the stool, petechiae, ecchymosis. They may be bleeding from their gums. Look for potential bleeding around venipuncture sites, taking longer to stop the bleeding after IVs are placed or pulled out, or IV, not just IV, but venipuncture occurs. So if there is bleeding, then the patient should be taken off the drug immediately. And for severe bleeding, that the reversal agent is called protamine sulfate. So in this case, 1 milligram of protamine can reverse 100 units of heparin. If we look at the normal dosing of heparin, a patient's usually getting 5,000 units sub-Q and potentially a lot more IV. Okay, the next medication is warfarin, which actually was used as rat poison and I believe still is. So it used to be a very, very commonly prescribed medication. In fact, I want to say it was one of our presidents who was on it following a heart attack. Yeah, you'd have to fact check me on that, but I think it was Johnson. But anyways, it was the most common one. In fact, the hospital I work at had a whole department that was dedicated to monitoring patients on warfarin in their labs and things. But it's losing popularity lately because of the basically science giving us better medications that have less interactions and less monitoring. It does take several days to become therapeutic, and this is why we may have the patient bridging from heparin and Lovenox. Lab values must be monitored, right? So a normal INR for anybody who's not on this medication should be around 1. We're talking seconds, the international normalized ratio. Therapeutic INR is 2 to 3 or 2 to 3 times the bleeding time. But if they're mechanical valve, we want it just a little bit higher. Lots and lots of drug interactions with this. Some people are not great metabolizers. Some people are great metabolizers, will have toxic effects immediately, sometimes just based on genetic variations. And there are genetic testings that can be done to see if they have any of these variations. Vitamin K is the actual antidote to warfarin, so we need to have our patient be consistent with their vitamin K. Most patients don't take a huge amount of vitamin K, so we tell them to avoid excess vitamin K. So if they eat a salad every day, that's fine. They can continue to eat a salad. But if they change their eating habits, it will change their INR. Contraindicated in pregnancy. And that makes sense, right? Think about what warfarin is doing. It actually inhibits the vitamin K. And babies who are born without vitamin K can die, and this can cause intrauterine demise as well. This whole purple toes syndrome, so they think that's due to small clots in the blood vessels, which causes this kind of bluish purple color in the toes and feet. It's fairly rare, usually in the first 3 to 8 weeks, but if it happens, the treatment is generally stopped because these clots can lead to the need for amputation. So bear that in mind. Let's look at the toxic effects of warfarin. So if the patient is bleeding, they have a really super high INR, we want to stop that dose of warfarin. Can take up to 42 hours or a day and a half or longer for the liver can sort of reverse warfarin. So if it's a really high INR, vitamin K administration can decrease that INR a lot faster. And if we can give it IV to reverse it within 6 hours. A lot of times we'll do this if our patient needs to have emergent surgery and there's no time to wait. Considering the treatment of warfarin toxicity you have listed here, basically if you give vitamin K, the body will continue to be resistant to the warfarin for up to 7 days. So that means you can't just reverse it with vitamin K and then give them the warfarin, because it takes several days for the body to kind of get back to that homeostasis with that. Homeostasis. If the person experiences severe bleeding, then they may need to get some factors given to them to help with the clotting. We do have things like Kcentra and Propylene, which are used to reverse the effects of warfarin, and some other blood thinners in case of bleeding or surgery. And anybody who receives IV vitamin K, there's a risk of anaphylaxis. So we can diminish that risk by giving it in a dilutional form over 30 minutes. So just little hints. There are a ton of herbal interactions with warfarin. They are listed here. All of these may cause increased bleeding when taking with warfarin. So pause and take a look at all of those. So as I mentioned, we actually now have medications that directly impact factor 10 or activated factor 10, which is 10A. So we do have inhibitors for factor Xa, and we have the direct oral anticoagulants. So these are more specific for factor X, and they don't require all of the monitoring that the other medications do. So these are the newest of the new. They used to be called NOACs, or novel oral anticoagulants, when I was first learning about them when I was in nursing school so many years ago. But now, because they're not really novel anymore, they've been out there called DOACs, or direct oral anticoagulants. So the ones that we use most often, I think, are ending with Axiban. So Xarelto or Rivaroxaban, Apixaban, those are the most common I've seen anyways. So fondaparinux is one that is available subcutaneously, and like all of the medications in this class, it can be used to treat or prevent DVTs or PEs. Of course, the side effect would be monitoring their bleeding potential, decreased platelets or thrombocytopenia. And for this one, we don't give it for 68 hours after surgery. We want the body to obtain hemostasis before giving this. Used very cautiously with warfarin. In fact, that's why it's generally not a warfarin bridge. Here's our exemplar DOAC. So this is Rivaroxaban. So this was the first one made. It's actually my favorite when I see the name brand because I love the shape of the pills. And then you can see the adverse reactions here. So what happens if we have toxic effects from these DOACs? For the longest time, we didn't have an antidote specific to these factor Xa inhibitors, but now we do have an antidote. We have this Andexxa. So it's a recombinant coagulation factor Xa, and inactivated, I have no idea how to say that, so I'll just say ZHCO. So again, this is something new that's come out. It's used for life-threatening uncontrolled bleeding. So it's not something we would pull out unless the patient really needed it, because otherwise we support patients through the toxic effects of these meds, usually by, platelets, blood, and other factors while the body sort of wears out its welcome on the drug. There is a black box warning on this medication about it causing sudden death. All right, so now we'll start to look at some of the direct thrombin inhibitors. So this is the class of medications that argatroban lives in. And remember, we talked about argatroban as a medication for those people who may have experienced heparin-induced thrombocytopenia. And that's because it's available IV. And the other common medication in this class is dabigatran, which is available orally. All right, so argatroban is used for heparin-induced thrombocytopenia, or also if the patient's at risk of HIT, for somebody going in for like a coronary intervention, like a PCI, or perhaps even, renal stuff, things like that. So basically any interventional procedures. So again, it's only available IV, and with this, we're still monitoring the PTT, I believe, on the argatroban. All right, so the next medication we want to look at is called dabigatran, or Pradaxa. So this is used for prevention of strokes related to atrial fibrillation. It is a prodrug, so remember, prodrugs have to be activated to become active. So in the liver is what activates it. It is normal dose for this is 150 milligrams twice daily, but will reduce the dosage if there's renal impairment. Most serious side effect, of course, is bleeding. And we'll take a look on the next slide about what the antidote is. Okay, so the antidote is diarasuzumab. So specifically for dabigatran, reverses it and is only used if the patient is in a life-threatening bleed or needs to have emergency surgery. All right, so the next thing we're going to talk about now are going to be our antiplatelet drugs. Antiplatelet drugs are those drugs which cause our platelets to be less sticky, right? It prevents platelet aggregation. Here is the huge list of antiplatelet drugs, and there are a lot. I've highlighted some of the most common, so aspirin, clopidogrel, integralin. So these are the ones I believe we take a look at here. But also some of the common ones I've seen out in the wild would be Prosidrel and sometimes ticagrelor. Those are the most common. So aspirin, we'll start with that because we've sort of talked about aspirin already under the NSAIDs, and we said that that medication did have antiplatelet activity. And here it is coming to treat patients for us. So aspirin, I think, is generally not given as monotherapy for people at high risk for coagulation disorders. For example, my patients who've had stenting, they're usually on clopidogrel and aspirin together. Remember not to use these for children. Aspirin is contraindicated in children with flu-like symptoms. And also enteric-coated aspirin is one of the more common forms given. It's enteric-coated to let it absorb more in the duodenum and also to protect the stomach and GI upset. So we don't want to crush those medications. All right. Also, there is a combo drug. There's Agranox, which is aspirin and dipyridamole. So two antiplatelet-ish aggregators together makes them very nice, very strong. So clopidogrel is going to be your very widely used antiplatelet drug, and it's oral. Normal dosing is that the patient gets loaded with a dose and then 75 milligrams a day. Lots of drug interactions with this one regardless. So, and the other ones that are similar to it are Prosidrel and ticagrelor. So you can see that they all have a grel in them. Integralin is one that you won't be seeing on the floor, but if you work in an ICU, you'll probably see it there. Also in cardiac cath labs. It is IV only. Now that we've talked about drugs that inhibit clot formation, let's talk about those that break down clots. So these thrombolytic drugs are those that lyse or break down clots that are in existence. So some of the older drugs, which are still in play today, streptokinase, urokinase, but currently most commonly will be used is T-plasminogen activators, or TPA. These would be things like alteplase and tenecteplase. So there's a little picture of what they do, right? They actually break down the clot. So these are the ones that are used for stroke and things like that. They are the ones that activate that fibrinolytic system, break down clots and vessels pretty quickly. So remember, they lyse or dissolve the thrombi. They don't prevent further clot formation like our other ones do, but they are definitely useful in breaking down what's there. These here are all the indications. So people who are having heart attacks, they have arteries blocked with clots because that can cause a loss of a limb or an organ. DVTs, if they're severe, anything that has a shunt occlusion or catheter, so we might have leg bypasses, things like that that are occluded. PEs, and of course our acute ischemic strokes. This is the one where we say the patient has to get to the hospital and have this TPA within a certain number of hours. That's this one, okay? Let's look at the side effects. So bleeding is going to be our most undesirable effect of any thrombolytic drug. I say most common bleeding. All right, it can be internal bleeding where we're not going to see it. So things like bleeding in the GI system, and you can see the signs and symptoms of that right here, right? That you might end up with decreased pressures and restlessness, pulse rate increases as the body tries to compensate for blood loss. If there's bleeding in the brain, you may see a headache and altered mental status. And if there is superficial bleeding, then the IV sites may be bleeding from the gums, different little capillary bed areas and closer vessels. So let's take a look at alteplase. That's going to be our exemplar. All right, so alteplase or Activase is TPA. It's really fibrin specific, so that's good. We do have some in our body anyways. It's only got a 5-minute half-life, so that's why It's given IV and given for heart attack and strokes. And when you see somebody has alteplase on their med reconciliation for the hospital with PICC lines, that is to open up the PICC line. Now, as we go into the next class of drugs, these would be the ones that work against fibrinolysis. So promotes the formation of clots. And these are very important for our patients who cannot make good stable clots, like hemophilia and von Willebrand's disease. And some of the drugs that you will become familiar with would be aminocaproic acid, tranexamic acid, and desmopressin. So those all, again, promote clot formation, prevent lysis of the clot. Of course, if we're giving something to promote clotting, then one would think that the most adverse effect would be clot formation, maybe a thrombotic event, and some of the others are listed here. So let's take a look at some of these drugs. Aminocaproic acid is one that we use following surgery. So people who have a lot of bleeding in surgery, and if we know that they're going to potentially be bleeders, then we would give it preventatively. There's an oral form as well as parenteral. All right, so tranexamic acid is basically a medication that's given IV, and it's used to prevent bleeding during surgery. But of course, this medication can cause decreased blood pressure if we give it under rapid IV infusion. So tranexamic acid is also used for people with hemophilia. Basically, anytime we're going to do an invasive procedure for somebody with hemophilia, this might be a medication for them before and for several days after, whether it be like a dental procedure, like a tooth extraction, or a minor surgical procedure. It's also given for females with heavy menstruation. All right, and just a little nod here to what hemophilia is. This is a genetic disorder. It is a recessive disorder. So basically, the person to be affected has to get a copy from mom and dad. Because of that, it's considered to be X-linked. So very more common for a boy to get it and actually have hemophilia because they only have one X chromosome. And for the females, they'll generally be carriers. And one of the most common families to have this in is the royal family, which is, we know there's a lot of it in there because they really had a lot of close family marriages, so they tend to have more of these autosomal recessive genetic disorders. So the problem with hemophilia is that the patient can actually bleed to death if they don't have those factors given. And there's a couple different types of hemophilia, which you talk about in probably pediatrics and also in some of your other medical surgical courses. So factor 7 deficiency, factor 8, and factor 9. So I put a picture of the queen here. This is her children. This is Queen Victoria. Many of her children had hemophilia, her boys. And one of the treatments for hemophilia is desmopressin or DDAVP. So this is very similar to antidiuretic hormone, which it's also used to treat diabetes insipidus. If you recall our lectures earlier regarding diabetes insipidus, and also it can be used for bedwetting in the nasal spray. But for our patients with hemophilia, we're going to be using it parenterally. All right, guys, this was another long one as we went through all the medications that can basically help us work against clotting, break down clots, help us form clots. And so here we are. I'll leave you with our cartoon, and I hope you have a great day.